So coming to the treatment part on the specifics, the lot of been we are listening about. We are being constantly on the WhatsApp messages are coming that the genomic sequences are similarity with the HIV virus itself. So initially it started more of an empirical, the combination of antiretroviral therapy and even some specific antivirals. So and now the new trial has come. So we'll talk about that later. So to start with, that is NHS specifically recommending any antiviral or a combination of antiretroviral therapy?
So there was a lot of, again, new disease. No one really knows why, but what is the exact treatment? And as we know, New England Journal paper from China that has shown that lopinavir-ritonavir combination has not really shown any outcome benefit. And therefore, there's a lot of interest on that, which is now people are a bit not sure exactly what that's going to do, and individually hospitals are trying to decide what combination they will use. Now empirically some hospitals I believe are using this combination. A trial is coming, recovery trial in the UK is coming with 4 arms. One arm has got interferon, other arm has got this antiviral combination, the other arm is placebo, and other arm is low dose dexamethasone. And for example, our hospital is going to recruit into that, hopefully fairly soon. And a solidarity trial is coming from WHO, and that has got all the right sort of drugs, if you like. The antiviral combination and chloroquine is also there. So I think a chloroquine trial is really important because that is causing a lot of questions and unanswered questions at the moment. Because if you look at all the data, this is all in vitro. Not only in vitro, it's almost cell line data. It's not even on animal level. And of course, it has got lots of beneficial effect. And the trial from France that has come out last week, that has only 30 odd patients. And in the control group, they hardly measured viral load, and they have measured viral load in the treatment group, and they have shown benefit. And this is an open label trial as well, so it's not, it's hard to just rely on that trial and then practice this widespread globally. So far we have decided that we would use chloroquine or hydroxychloroquine only in the context of a trial, not otherwise. And definitely there is no talk of prophylaxis in the UK with chloroquine. However, we accept that this may be something that we'll use very widely at some point. Chinese trials have completed and they have not published their data, so it will be interesting to see what comes out of that. But until then, just to give you one example why you should be careful, doctors don't do any harm. If you look at chloroquine and all the side effects, forget QT prolongation, everyone knows it. But chloroquine can cause cardiomyopathy as well. So if you have got 2,000 patients who have had COVID-19 and all of them had chloroquine, and say even 0.5% had cardiomyopathy and they had a very high troponin, then you would start describing that as part of the disease process, when actually it was chloroquine side effect. So until we know in a proper controlled trial setting what is the result, it's very hard to prescribe it. So we gave it a very hard thought in our hospital at least. We have talked about using in an unlicensed way, but we have decided against it. And many hospitals, I believe, are doing the same.
So what is the NHS protocol right now?
Say that again.
In Medway specifically.
NHS protocol right now is supportive therapy, ARDS management, do the basic ARTSNet management of these patients and recruit patients into trial when they're available. But it is accepted, obviously, that if a hospital on a patient-by-patient basis uses any particular drug, that's also obviously is okay. And remdesivir was available until last week on a compassionate ground from the Gilead company, but that has stopped as of now. Over the weekend, they have said that they are receiving so many requests, they are flooded, and they will change their plannings. They have withheld the compassionate ground prescription for remdesivir as well. And that drug, obviously, remdesivir is going to be a very interesting drug, and that is I forgot to mention, that is part of the solidarity trial that WHO has launched. So we need a very quickly set trials, and that's something that will give us proper answers. But we are not routinely prescribing drugs for these patients at the moment.
We also heard a lot on the cytokine storm and whether reducing that part,
Yes.
whether by disease modifying agents or maybe interferons or cytokine removal or a pooled plasma, are these would be helpful on any part? There are a lot of anecdotal reports. Your view on this?
Again, this is based on pathophysiological pathway of the disease. In some patients, the Chinese data suggests that there has been cytokine storm, and tocilizumab has been helpful. And it's been suggested that and that's why it's probably important to identify the disease process. And that's why I mentioned before that probably every other day or every day, in whichever is locally deemed appropriate, people will have to do regular and variable sets of inflammatory markers. And then you can think of, say, if you can't use interleukin 6, for example, for deciding who gets tocilizumab. If IL-6 is very high, you give tocilizumab, that's fine. But actually what that does to the patient in the context of the overall disease process, no one really knows. In terms of the disease pathophysiology, yes, IL-6 is high, you give tocilizumab, it might be helpful. But actually, it may be harmful. We don't know that yet. It's kind of trying to do your best when you have got no tool left. We are in that sort of state at the moment. Currently, what's been suggested in some quarters is that if your patient is not getting better and your ferritin level is going higher or remaining high, this is something that can be considered. But again, this needs further testing.
And okay, so as of now, so you can say that it's more of a trial basis. Whosoever patient gets enrolled into any trial will receive either a form of combination of antiretroviral,
Absolutely,
remdesivir or hydroxychloroquine or a placebo even, right? So only after those trials, at least the interim analysis are out, then you get to know. So that is the situation.
yeah.
And we are very, very specific about not recommending hydroxychloroquine as prophylaxis, because a lot of healthcare workers and even patients, they are panicked and they are actually stockpiling it in India of hydroxychloroquine and azithromycin combination.
Yeah.
And obviously our great Donald Trump,
Yeah.
the biggest physician at this moment of time, he has added to it, right? Hydroxychloroquine, how he has pronounced it, that's a separate issue. Yes. So are you with more of conviction? You are saying that NHS is not recommending neither using hydroxychloroquine to be as a chemoprophylaxis for healthcare workers who are exposed. Because right at this moment when I am talking to you, Indian ICMR, Indian Clinical Medical Research Society, ICMR, Indian Council of Medical Research, they came up with the guidelines where they are actually suggesting hydroxychloroquine as a prophylaxis to healthcare workers who are exposed to patient relatives who had confirmed cases.
Yeah. And it is also true that they're also suggesting that whilst they take the prophylaxis, to take all the other precautions. So that means that no one really knows whether this will be totally helpful. So you still take the isolation approach, etc. It's a hard decision to make, because this is a population level decision. NHS in the UK, it's not advised at the moment. It is very difficult for the policymakers to come to a judgment on this, because there is a lot of noise on hydroxychloroquine, and at a molecular level data, there is lots of evidence that yes, there is a lot of lung concentration of hydroxychloroquine, and people are going for that. But we must remember that chloroquine had a lot of activity in vitro on chikungunya, and when it came to patient use, there was no benefit on chikungunya on chloroquine. So when it comes to actual patient use, it might give you false sense of security, and that's a risk. But I'm sure everyone whoever has taken this approach has given it a balanced thought and judgment, and that's why they have come up with the guideline. And I'm not going to comment on that. But at the moment here, there is nothing. It's not in the guideline that we use those things as prophylaxis. And we must remember there is no patient level or human level good amount of data, and they are usually safe, but there are side effects.
If we are deciding to treat the patient with any form of therapy, pharmacotherapy, right? When are we starting? Are we waiting for the patient to sort of justify the treatment, or he earns his own treatment? We wait till the hypoxia worsens all others, or it is from the very beginning when a patient gets positive?
So the initial experience of chloroquine is from China, and from what I have found in Chinese guideline, I need to uh, I need to double check that again, and everyone needs to look it up themselves as well, because Chinese guideline you have to kind of translate in Google Translate, etc. That they are not suggesting that you use them in mildly infected patients. You only use it in really sick patients after some days. So it's not for everyone to have. If someone comes in with a mild amount of low FiO2, etc., they are not suggesting you have them. It's only when they are not getting better, physiologically unstable, at a slightly later stage of the disease, you use that. That's the Chinese guideline, and they have got the most experience with this probably. And when the Chinese trial data comes out, we'll find out. So in a nutshell, not from day one. That's what was my take on the chloroquine side. And same with same so far the how the people are choosing which patients to give antiviral, if at all. This would be for patients who are more sicker, because clearly we are not going to be able to give antiviral to everyone, and that's not how it should be, because mostly it's a self-limited disease.